Hi, this is my presentation for my capstone, hypothermia in trauma patients, and how controllable hypothermia can be. But one of the newest additions that seems to be happening in the medical field is the overwhelming influx of new graduate nurses. So this is my presentation on hypothermia and how it relates to new nurses in the workforce in critical care areas. There is a triad of death in all trauma patients that medical professionals are aware of. It's a systemic trifecta of things. You don't want to get behind the eight ball. If you get behind the eight ball, it's a cycle that just keeps happening. Hypothermia being one of those things in the triad of death. And the biggest thing is it's the easiest to control. And by the time the patients come into a medical facility, they're already behind the eight ball with field exposure. But those three steps in the triad of death, it's hypothermia, acidosis, because they're hypovolemic, lots of blood loss, and coagulopathy. So you lose a lot of blood, you have to replace it, so you're not clotting, so it leads to multi-organ failure. The biggest thing in the triad of death, and the easiest to intervene, were very rapid, without any type of order, is hypothermia. The importance of temperature control in the lethal triad is you want to avoid the systemic three steps that happen. So you want to avoid those steps. And to avoid those steps, the biggest one and the most controllable, again, is temperature control. What happens is you get hypothermia. If they start, the patient loses a lot of blood loss and they get hypovolemic. They get multi-organ failure is exacerbated. Hypothermia also is included in that. And then it increases mortality and morbidity for patients. Once you ever hit that triad of death, it is known that it's hard to get out of it, so you want to stop it before it happens. And hypothermia, low temperature, is considered an ominous sign of stepping into that triad. Risk factors for hypothermia, again, field exposure. By the time a patient already arrives to the trauma center, 43% of those patients already arrive hypothermic. Not that EMS is not doing what they're supposed to do, but just field exposure. Patients are wet, clothes have been cut off, they've sometimes urinated, peed on themselves, they've already lost blood. All those things are making them wet. The temperature outside, are they in a rural area? Is it cold? Mechanism of traumas, blunt force, causing a lot of friction and shear. So you're bleeding internally. You may not see it outwardly, but you see it internally. So things that you want to do in rapid infusion. So you go, okay, someone's hypovolemic and they've lost a lot of blood. We need to rapidly infuse them. But if you rapidly infuse cold intravenous fluids, EMS doesn't have the ability to initiate a warming machine. That also puts them at risk. And delayed assessment and reassessment of temperature in the trauma center is on arrival in primary survey. Temperature is not in the primary survey. It is part of vital signs, but we want to rapidly get a temperature. And blood products. When they come to the trauma center, they need blood products, and a lot of times they need it rapid. And what blood comes out of the fridge, right? So you don't want to rapidly infuse that cold also. So rapidly infusing blood products puts them at risk for increased hypothermia. Temperature assessment is very important. You want to do it. It wants to be a priority. You want to do it very quickly on arrival to the door as soon as the patient gets moved over. And of course, airway is important, but temperature control. Take that first core temperature, evaluate it, maintain it. As soon as the patient is starting to show signs of shivering, you're behind the eight ball. So as you do that rapid primary survey, that rapid primary assessment, you've taken a core temperature, you want to rewarm, put warm blankets on that patient. The clothes are always being removed from trauma patients, so rewarm them. Warming measures include, like we said, blankets, which is a quick intervention. It's non-invasive. You can grab them, throw them on the patient. Bear huggers. We use bear huggers to warm them up. It's just a blanket. You plug in hot, warm, puffs up over the patient. And you can use intravenous warmed crystalloids, and that's out of a warmer, not necessarily the rapid infuser, but we do have a rapid infuser that rapidly infuses all blood products through a warming machine. And it goes in cold, comes out to the temperature of the body. Nursing and hypothermia in trauma patients. Knowledge base is critical. This is where our new nurses that are being put into areas such as these, it's a disservice to them. One, they don't know. They don't have the knowledge base to pull from. So they're not aware, they're unsure. But knowledge base is critical. Strong assessment skills, knowing it's okay. You have to sometimes push the doctors or push the PAs out of the way and say, I need that temperature. We need to keep the blankets on. You need to wipe that lubrication off that you did an ultrasound. All those things continue to make the patient cold, whereas new nurses are afraid to kind of bump their way and get their way in there. You want to be proficient in multitasking. You're taking a temperature at the same time the doctors are doing an ultrasound for a fast exam using ultrasound jelly. You want to remind them, remember to remove that gel. That's going to drop that patient's temperature. And excellent communication skills, communicating within the team. New nurses sometimes just don't know how to do that yet or feel a little bit uncomfortable with that. Experienced nurses versus new nurses, again, critical care nurses are leaving the bedside. They're advancing their education, their ARNPs, their DNPs. So those critical care nurses are leaving. New graduate nurses are coming in, and they have no critical care nurses to follow in their footsteps, to mentor and to bring up, to say, hey, it's okay. You got to bump that out of the way sometimes. And, with good communication skills to take that temperature. And nurses with less than 1 year experience, still coming into critical care areas like the level 1 trauma centers, ICUs, SICUs. They lack that critical care training. They lack that confidence. So it's a disservice to them and it's a disservice to the patient. Changing the orientation model. One of the articles I researched was an article about actually incorporating a new nurse fellowship and more like a residency program, like they do with doctors. Yes, you get a lot in nursing school, but that's just it. You don't get a lot of hands-on because there's so much curriculum. So developing a fellowship or a residency program for new nurses would be just as beneficial as it is for physicians. It would provide more than basic hospital orientation, and you'd partner with new nurses would partner with critical care nurses, and they'd utilize the critical care educators, and they would allow for continued feedback and orientation, and they'd base your orientation off of those needs. The benefits of a critical care fellowship is you would become more increased in your knowledge, you would have more confidence in your skills, in organization skills, time management, and communication skills. And new nurses that they interviewed and they studied in this article, they enjoyed it. They felt better. They liked the fellowships. They felt more confident. They felt coming out of it that they were more prepared. So in conclusion, we want to decrease our risk factors for hypothermia in trauma patients. We want to assess and reassess temperatures in trauma patients. We want to be knowledgeable in the warming measures. And we want to improve orientation for unexperienced nurses in the critical care areas. And we want to stay away from the triad. You get in the triad, you can't get out of the triad. So decreasing hypothermia and being vigilant is one of those ways. These are my references, and I hope you enjoyed my program. Thank you.